Welcome to AETCM, the emergency medicine channel. So, as a part of the EM Rapid 2023, we're going to discuss topic of acute aortic syndromes. So, acute aortic syndrome, it's a life-threatening disorder. It comprises of lot of disorders which usually which occurs in the thoracic and abdominal aorta. Here, acute means the settings here. The symptoms occurs within 1 to 14 days of the initial clinical presentation. The disorder occurs within 1 to 14 days, and it contains lot of spectrum of life-threatening aortic emergencies. The most common being the aortic dissection, and other ones which we have to be noting are the intramural hematoma and the penetrating aortic ulcer and ruptured abdominal aortic aneurysm. The other which are least important are the intimal tear without the hematoma, periaortic hematoma, aortic aneurysmal leakage. So we'll discuss about the further risk factors for the emergence of this aortic syndromes. The main risk factors are the chronic hypertension, then like the factors which lead to the degeneration of the media of the aortic valve, like the bicuspid aortic valve, Marfan syndrome, Ehlers-Danlos syndrome, then family history of any aortic dissection. So, other than that, chronic cocaine or amphetamine use also increase the atherosclerosis and thereby can lead on to dissection. Prior cardiac surgery is also a risk factor for the same. So, these mechanisms will cause the weakening of the medial layer and thereby increasing the intimal wall stress. Here we can see the structure of the aortic wall. So it can be divided into three: to intima, then the media, and external adventitia. So when there is some weakening of the medial layer, when there is a tear on the intimal region, the blood can get into the medial in tunica media, and thereby from there the blood can move in anterograde or retrograde manner. So here the response to stress, as we discussed earlier, the intimal stress, when there is an intimal wall stress, the response to stress can be aortic dilatation or can be aneurysmal formation, or the most common aortic dissection that can go on to an aortic rupture and development of penetrating ulcer and also an intramural hemorrhage. These are the pathways to the stress in the intimal wall can go on. So we'll discuss about the aortic dissection at first. So it's occurs after there is a stress or violation of the intimal wall, which will cause the blood to enter into the tunica media, and then from that point the blood will go in between the intimal and adventitial layer, and there will be a creation of a false lumen. So the blood will move in an anterograde or a retrograde manner, and it will be within the outer third of the tunica media. So there are many sites where in which the blood will enter into the tunica media. The most common being the sinotubular junction, and it is near the ascending aorta region, that sinotubular junction. Then the next one is the just beyond the left subclavian artery at the junction between the ascending and the descending aorta. This is the most common 2 points where there will be the starting of an aortic dissection. So the blood may dissect, and here the after entering the blood may dissect and re-enter the intima, and it will go on with the normal blood flow, or else the blood can dissect through the adventitia. That is a very fatal condition, and blood can move out and can become a rupture. So that is a fatal condition. The other one, we can get misdiagnosed as the patient might not have significant symptoms at that point of time. The blood will go through the tunica media and will re-enter the blood supply, so through that intima. The aortic dissection follows a bimodal age pattern, most commonly seen in young patients and also in the elderlies. So in young patients, mostly it occurs due to connective tissue disorders, and which will cause the intimal tear, through which there will be medial stress, and through which the blood will be moving through and from motion in the tunica media. And in above the 50 years of age, the patient with chronic hypertension or CAD can be a risk factor for the development of the same. So the aortic dissection, we have main two classification to divide the aortic dissection. So they are the Stanford and Debicki classification. So Stanford classification has type A and type B. So in type A, it involves ascending aorta and can progress to the arch of aorta, and later on the abdominal aorta, descending and abdominal aorta. Type B involves only the descending part of descending aorta or the abdominal aorta. And wherein Debicki classification can be divided into three parts. So type 1 involves the ascending aorta and arch of aorta, and descending aorta may progress into the abdominal aorta, wherein which type 2 is just confined to the ascending aorta, and type 3 involve the can be divided into two parts. So type 3A involve the descending aorta, and whereas type 3B involve the thoracic and abdominal aorta. So in Stanford type A means ascending arch of aorta and descending can be involved. So it can be so Stanford A means it can involve Debicki type 1 and type 2. So Stanford type B means Debicki type 3. So can be the Debicki type 1 and type 2 can be combined into a Stanford type A. These are the two classifications for the same. So pathophysiology of the aortic dissection rupture. So consequences of this rupture is that mostly the blood will go on to multiple sites. Mainly it can go on to form hemopericardium. Patient can have syncope, sudden death, hemothorax, mediastinal hematoma, then can form a interatrial septal hematoma, and so rarely the blood can go into esophagus, which will go into hematemesis, and the compression of pulmonary artery or pulmonary trunk. Then retroperitoneal hemorrhage can occur when the abdominal aorta is also involved, and rarely intraperitoneal hemorrhage also can occur. So acute intramural hematoma. Here there will be a hematoma formation. That the collection of blood will be within the medial layer of the tunica media layer of the aorta in absence of a detectable intimal tear. So here there won't be an intimal tear. As in aortic dissection there was an intimal tear, but here there won't be an intimal tear. The main cause for the same is that there will be a vasa vasorum. This vasa vasorum is the blood vessels which supply the artery itself. So there will be a injury to the vasa vasorum can cause collection of blood and hematoma in the tunica media, or due to an aortic injury. So mostly can associated with type B descending aortic dissection, and can resolve spontaneously or can lead on to the formation of aortic dissection, aneurysm, or rupture, and mostly seen in females. And type A is type A and type B Stanford classification. So in type B, medical management can be done, and type A usually early surgery will be needed. So we can see in this picture that there will be the intramural hematoma. There will be formation of hematoma over in the medial region due to the vasa vasoral tear or vasa vasoral vessel ruptures. These two are the intramural hematoma part. Then the other one we have to discuss about is the penetrating aortic ulcer. The ulcerating atherosclerotic lesion in the intimal layer that penetrate the elastic lamina, and it will form a hematoma, and formation will be within the media of the aortic valve. So it is mostly associated or mostly seen in the descending aorta, and you can see that there will be a penetrating ulcer which will go on to the ulcer which will go on to the tunica media region, and this ulcer will can lead on to intramural hematoma formation. As ulcer, there will be blood will move into the media region and can form into hematoma, or else it can form into a aortic dissection or perforation of aorta can also occur. So clinical features of the aortic dissection. So main clinical feature of the patient with aortic dissection is that patient will have severe abrupt and severe pain, mostly in the chest region, that will be mostly confined between the two scapula, and the patient will be feeling like the patient is going to die suddenly. It's a sudden feeling of impending doom. The patient can have this feeling of impending doom. And the other one we had to look forward is that the patient can have anterior chest pain, most commonly seen in Stanford type A. There will be anterior chest pain, and whereas then Stanford type B, as we have discussed earlier, Stanford type B mostly seen in descending aorta and abdominal aorta. In Stanford type B, patient will have abdominal pain. Dissection in or near the carotid artery can or may present like a classic stroke features. And because and the other one, the interruption of the blood supply to the spinal cord can also occur due to the dissection, which can lead on to paraplegia also. Classic stroke and paraplegia, these are more neurological symptoms can occur. Then distal dissection, as I told earlier, like Stanford type B, distal dissection can present like back pain, flank pain, or abdominal pain. Back, flank, and abdominal pain. Proximal dissection can also uh, go into the aortic root. That can in turn lead on to the cardiac tamponade also. These are the main clinical features. So signs like following the aortic dissection is that hemopericardium can occur. So following the hemopericardium, pulsus paradoxus can be seen. Pulsus paradoxus can be seen. Then that is the during inspiration the pulse will be the BP will be more than 10. Then the faint heart sound can be seen due to the hemopericardium. Then distended neck veins can be seen. Patient can go on to shock. And when aortic root dilatation is there, we can see aortic regurgitation murmur can be there. Then incomplete opposition due to the root dilatation. The aortic leaflets won't be completely opposed. So incomplete opposition of the aortic leaflets can occur. Then pulse pressure can be widened due to the aortic root dilatation. So there will be due to the compression of true aortic lumen, a systolic murmur over the aorta can also occur. Then other thing we have to watch out for is that the pulse deficit in radial and femoral artery. So that is also a feature we can see. Then BP will be more if the BP is more than 20 in the between the two different dams, then it is a most commonest feature seen in the aortic dissection. Patient can have hypotension or hypertension. So and patient like if patient can have dysphagia, hoarseness of voice, Horner syndrome. This can occur due to the compression of esophagus, then laryngeal nerves, which will cause the hoarseness and Horner syndrome. The main investigations of choice for the main investigation which we had to do for finding the aortic dissection is that initially itself patient will come with chest pain, so we had to do an ECG to rule out whether the patient is having a aortic dissection or ACS. So ECG to rule out whether there is an ACS, but in type A dissection we itself can cause ACS also. We had to but rule out ACS as such, and if at all there is an ECG showing features of ACS also, we cannot rule out aortic dissection. So D dimer, if the D dimer is less than 500, then it is we can rule out aortic dissection. Then the other one we have to look for is the chest X-ray. Chest X-ray will show multiple features suggestive of aortic dissection. The main ones are widened mediastinum, abnormal aortic contour, pleural effusion, displacement of aortic intimal calcification, then deviation of trachea, or the bronchi or esophagus. So these features can be seen as here, the abnormal aortic contour can be seen here. These usually asked in the exams, these X-ray features. Then transthoracic echo may reveal intimal flap within the aortic lumen. Other than that, the transthoracic echo shows aortic regurgitation, hemopericardium, and ischemic changes. Usually, the sensitivity is like 80% for type A and 50% for type B. Transesophageal echo is a very good modality for unstable patient with a high sensitivity of 90 to 98%. If transesophageal cannot be done, a CT angiogram can be done, and CT angio or MR angio is the imaging modality of choice uh, for the diagnosis of the aortic dissection. And treatment for the same is that the patient will be coming with severe pain. Initial management will be, we have to secure two large bore IV cannulas, followed by we have to monitor the patient and O2 support, and followed by pain management have to be given. So pain management, IV opioids, fentanyl can be given. Then if the patient's history is suggestive of like a aortic dissection, you don't give antiplatelets, heparin, or thrombolysis, as it can go into large amount of hemorrhage. Then patient should we should very fastly consult with the vascular or CVTS surgeon for further management of the same, and the surgeon will be deciding upon whether the open repair or endovascular repair might need. Type A dissection usually require surgery to prevent any rupture into the pericardial sac. Whereas in type B dissection, medical management can be done, uh, and endovascular stenting it can be done if the patient has persistent pain and or the rapidly expanding due to rapidly expanding aortic diameter or malperfusion of branch vessel organs. Medical management for aortic dissection involving descending aorta can be done without any in cases where there is no signs of any ischemia or symptoms of ischemia. Here the medical management is that we have to reduce the BP, and it's called anti-impulse therapy, where it will reduce the rate of progression of the dissection. Decrease here we decrease the velocity of the LV contraction, and which will decrease the shear stress by minimizing the progression stress, and thereby minimizing the lesions progression. We have to maintain a target BP of 100 to 120 with the heart rate less than 60 for getting the medical management, means the BP should be controlled. So here we use two type of drugs, the negative inotropic agents and vasodilators. Initially we use the negative inotropic agents, that is the esmolol and labetalol. So we can use either of this. Esmolol can be given as initial bolus of 0.1 to 0.5 milligram per kg IV over initial first 1 minute, followed by an infusion of 0.025 to 0.2 milligram per kg per minute infusion. Labetalol can be given as a IV doses of 10 to 20 milligram with repeat doses leading to 20 to 40 milligram every 10 minutes, and the maximum dose up to 300 milligram. So in decompensated heart failure, we avoid these two, esmolol and labetalol, and we can use dilsam or verapamil. And when once the initial BP is controlled with the esmolol or labetalol, then we can go on with the vasodilators for BP control. We can use IV nicardipine, then clevidipine, then nitroglycerin or nitroprusside. So the next the aortic syndrome we have to discuss is that the symptomatic acute abdominal aortic aneurysm and aneurysmal rupture. So most common one is the infrarenal abdominal aortic aneurysm, and the other ones are like renal and the visceral ones like our renal aneurysm. So infrarenal aortism can be said that infrarenal abdominal aneurysm if the size is diameter is more than 3 centimeter. If it is called a suprarenal abdominal aortic aneurysm, it should be greater than 0.5 of than the infrarenal one. So 3.5 is the minimum, uh, the one needed for telling that suprarenal is an abdominal aortic aneurysm. If if the size of the abdominal aortic aneurysm is greater than 5 centimeter, then it is warranted for surgery. Surgical repair is needed. And because if risk of abdominal aortic aneurysm rupture increases when the size is greater than 5.5 centimeter. So aortic rupture is due to the weakening of the aortic wall, which will lead to the tearing of the aortic wall, allowing the blood to escape out to the outsides of the aorta. In condition where there is an absence of rupture and the patient is complaining of pain, that can indicate that there is a rapid expansion of the aneurysm, causing compression of the adjacent structures or an inflammation of the aorta or aneurysm or infection of the abdominal aortic aneurysm. So we can discuss about the risk factors for the same. So risk factors for developing the abdominal aortic aneurysm is like first, in patients with the first degree relatives having abdominal aneurysm in race of height. So when there is an increasing age greater than 60 is a main risk factor for the same. Then mostly seen more in males than females, and in condition where there is patient having hypertension, dyslipidemia, and peripheral arterial diseases, patients with major artery aneurysm, and connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, Loeys-Dietz or Turner syndrome, and smoking is a very important risk factor for the same. So patient with smoking, there is 4 times more chance to develop abdominal aortic aneurysm. And for risk factor for the rupture of the aneurysm, abdominal aortic aneurysm is that aneurysm size, as discussed earlier, greater than 5.5 centimeter, with the patient having smoking, elevated BP, hypertension, and females with who are symptomatic, and there is a also the aortic expansion rate is more than 0.5 centimeter per year. If the rate is more than 0.5 centimeter per year, there is high chance that the patient's aneurysm can rupture. These are the main risk factors. So the main symptoms for abdominal aortic aneurysm is that the patient will complain like abrupt onset of back pain or abdominal pain or flank or groin pain. The patient will complains of sudden abrupt pain like ripping, tearing pain. Patient can also have nausea or vomiting, and patient can complain of tenesmus or bilateral lower limb ischemia because of the embolization of the thrombus in the aneurysm. Then a patient can have unexplained upper GI bleed from the aorta entry fistula. That occurs usually in patients with a history of aortic graft replacement. Then patient, due to the rupture, patient can go on into shock and shock or syncope, and sudden death can also occur. So main symptoms as such here we have to discuss is that there is a triad for abdominal aortic aneurysm, where the patient will have an abdominal pain with hypotension and a pulsatile abdominal mass. These are the triad for abdominal aortic aneurysmal rupture. Triad: abdominal pain with the pulsatile abdominal mass and hypotension. So the sign for abdominal aortic aneurysm: there will be palpable pulsatile mass, and there will be tenderness over the abdominal aortic aneurysm. Patient will be in hypotension with a tachycardia, and in a rupture, the patient, there will be ecchymosis, para-umbilical ecchymosis, which is called Cullen sign. Then there will be Gray Turner sign, where there will be flank ecchymosis. Then there will be Bryan sign, where the discoloration of the scrotal region. Then Fox sign, there will be proximal thigh ecchymosis, and retroperitoneal blood can dissect into the perineum and groin, causing scrotal, vulvar, or inguinal region hematomas, and also can cause psoas sign due to the irritation of the psoas muscles. Patient can have neuropathy due to the irritation of the femoral nerve. Then other than signs of high output cardiac failure can be seen in aorta venous fistulas. So here the investigations that we have to do is that in unstable patients we cannot shift the patient for imaging modalities in the radiology room. So bedside ultrasound can be done. So bedside ultrasound is the imaging modality of choice for patients with unstable patients. And if at all in the bedside ultrasound, abdominal aorta greater than 3 centimeter in size is suggestive of acute aneurysmal disease. In stable patients, we can do CT abdomen with IV contrast other than the ultrasound. And in stable patients, abdominal X-ray can show calcified and bulging aortic control more in the lateral view. And we can do MRI and CT abdomen in stable patients. So here the treatment is that we have to realize that the patient is having abdominal aortic aneurysm, and early recognition of the condition is needed, and we have to support the patient with two large bore IV cannula, cardiac monitoring, O2 support, and if at all this is the abdominal aortic aneurysm, early surgical consultation is needed, vascular consultation is needed. So, if the patient is asymptomatic, so medical or elective repair can be done. This is decided upon by the surgeon. And in hemodynamically unstable patients with a ruptured abdominal aortic aneurysm, so the patients are directly shifted from the emergency department to the OT. For patient is at this point of time also patient be having severe abdominal pain. So pain control have to be given. Pain control IV sedatives and IV analgesics like fentanyl can be given. And also patient's BP should be maintained in a hypotensive state. That is permissive hypotension should be maintained with a systolic BP of 80 to 100 mmHg. Whereas in aortic dissection, the BP we had to maintain was 100 to 120. Here the BP is bit lower than that, 80 to 100. And this will prevent further tear of the aorta, and had to do volume replacement if the patient's consciousness is going down. And to reduce the BP, we can use esmolol as the treatment, esmolol IV. Other wherein which in aortic dissection we had used esmolol and labetalol. Here esmolol 1000 microgram per kg is given over 30 seconds, and this is followed by 150 microgram per kg per minute infusion. And if the BP is high after the initial bolus dose, and patient can may require massive transfusion also, and uh, patient might need Ribova technique for a ruptured abdominal aortic aneurysm. Ribova means a resuscitative endovascular balloon occlusion of the aorta. This will occlude the aorta above the aneurysmal site, means from the site of rupture, from the above site of rupture we will occlude the abdominal aorta. This will also cause some complication like graft leak and occlusion. Renal dysfunction can occur because most common one is the renal aneurysms, wherein which it will be near the renal region, and if at all we are doing the rebo, which can go on to renal dysfunction. Aorta enteric fistula can occur, bowel ischemia can occur, and there will be in the case of operative region, in symptomatic patients, there will be twofold risk of perioperative mortality in symptomatic abdominal aneurysm, whereas there is sevenfold risk in perioperative mortality in ruptured abdominal aortic aneurysm. So that is about acute aortic syndromes, wherein which the most ones we have to study is the abdominal aortic aneurysm, ruptured abdominal aortic aneurysm, aortic dissection, intramural hematoma, and ulcer, penetrating ulcer. So that's it. Thank you.